Assalamualaikum warahmatullahi wabarakatuh. Uh, I am going to share a bit about thyroid. Not going to discuss the whole topic of thyroid. I just want to pick up one thing. When or what are the indications of thyroid surgery? Many of your patients ask whether my thyroid needs surgery, your thyroid needs surgery. When we or medical officer or house officer see the patient in clinic, in health site clinic, peripheral, in the ward, in the medical ward. When is the indications of surgery? Which kind of thyroid disease requires surgery? So as a doctor, you must know and you must have very clear knowledge about the indications of thyroid surgery. It's a brief classifications of thyroid disease. You can have non-neoplastic and neoplastic. The non-neoplastic benign conditions such as thyroid stress, hypo and hyperthyroidism. You can have multinodular goiter. You can have Hashimoto or any autoimmune thyroid diseases. These are non-neoplastics. And neoplastics, malignancy, like from papillary, which is differentiated follicular. Then you have medullary cystite, follicular parafollicular cells. Then you have undifferentiated, such as anaplastic. You can have other form like lymphoma. These are the neoplastics. Okay. So when you have goiter, can be unilateral, solitary, and after you club the patient, get the history, examine whether it is solid, single, size, and then you ask about the associated symptoms, any compressive symptoms, hypo or hyperthyroidism. So after you get all the histories, now the decision comes whether this patient need surgical intervention or not. So what are the first on top of the list where patient should be advised for surgery is malignancy. Okay, all type of cancer require surgery. Papillary, medullary, neoplastics, the patient requires surgery. The surgery is total thyroidectomy. How about follicular? Usually follicular neoplasm on FNAC, it cannot really confirm whether patient having follicular adenoma or follicular carcinoma. Only after because of the FNAC did not tell you about the capsular invasions. So that is important and mandatory aspect of making a diagnosis of follicular CD. So in this kind of case, 20% of cases are malignancy and another 80% benign. So usually we subject for hemithyroidectomy in the form of biopsy. Then after the result back, depends. But if it is adenoma, leave it alone. If it is CA, completion of thyroidectomy. Okay, malignancy number 1. Number 2, suspicious of malignancy. So if you suspect by FNAC suspicious of malignancy, this patient also require surgical intervention, but usually on the affected sites. Hemithyroidectomy. Third, what are the third? The third one is thyrotoxicosis, which has been treated under medical therapy and then been treated with radioisotope iodine and still fail. This patient should be subjected for surgery. Surgery means total thyroidectomy. Some patient contraindicated for iodine therapy, for example, lactating mother, pregnancy, or patient toxic goiter with eye sign, oculopathy. So this patient should be subjected for surgery. So you have malignancy, suspicious of malignancy, thyrotoxicosis, fail with medical and radioisotope therapy. The other one is fourth one is cyst. Any cyst bigger than 4 centimeter and after simple cyst or even complex cyst has been attempted for aspirations and failed after 1 or 2 trials, and the cyst is big, more than 4 centimeter, this patient should be advised for surgery, usually on the affected side, means hemithyroidectomy. And then multinodular goiter. Any goiter, especially in hypothyroidism, okay? In hypothyroidism, multinodular goiter, huge. Patient on thyroid, huge. Any goiter bigger and then causing sometimes obstructive symptoms, he should subject patient for thyroidectomy. And last but not least is for cosmetic reasons. For cosmetic reasons, multinodular goiter, hypothyroidism, where patient said this swelling causing disfigurement, malu and all things. So this patient should be subjected. That is under cosmetic reasons. How about autoimmune disease? These are very important scenario. Thyroiditis. Surgery in thyroiditis are not easy because of abundance of blood vessels, because of fibrovascular growing on that stage. So surgery will be actually challenging for surgeons, and the plane of dissection also difficult and can cause morbidity, injury to recurrent meridian nerve, and cause morbidity in terms of bleedings. So usually before you decide for surgery, make sure you exclude hypothyroidism due to autoimmune disease, Hashimoto thyroid, by sending this thyroglobulin antibody, antimicrosomal antibody, anti-thyroid peroxidase antibody. So usually we treat conservatively, unless patient have malignant changes, so it's rapid growing, compressive symptom, and all those things. So that is when you see the patient in clinic, these are the patients that require surgical intervention. Cyst 2 cm, 3 cm in size. You can just follow up with ultrasound, simple cyst, just aspirate. You don't have to operate. Patient with thyroid toxicosis but control with medical therapy, you can continue with medical treatment first, unless after 1.5 years, 2 years, patient still having enlargement, and then because of worried about this toxicity of this anti-thyroid drugs, we subject patient for surgery. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.